smile, whether there is a gingival display or there is a reduced incisor display or increased incisor display, that's smile. After that, on profile picture, the most important picture is the profile picture. You will get multiple information from this picture. You will get information regarding nasolabial angle. You will get information regarding the profile of the patient. You will get the information regarding whether it's a class 1, class 2 or a class 3 patient. You will get information regarding whether the patient is a horizontal growth pattern or a vertical growth pattern. You'll get information regarding nose-chin-lip relationship, which we also call it as E-line. So there will be multiple information. That's why I told you one of the most important picture is smiling picture frontal and profile picture, which is at rest. Alright? After that, you will take study models also. You can take digital study models nowadays, or you can take the traditional models. These traditional models are to be mounted. There is a different specific method to mount the model. That means your models will have specific ratio. That means your non-dental part and dental part should be in a particular ratio. It is 30, 30, 30. Alright? And also there is specific height. All those things are there, but it is not needed for you because it is lab work. Also nowadays we have digital models, so this is outdated. You don't have need that. And if you take good sets of photographs, which give you why do we need models? Because it's a 3D representation of your occlusion. You can see the occlusion from all the sides, especially from back, so that you can see the relationship of incisor occlusion, which you cannot see from frontal, isn't it? But if you take a good set of photograph, you will get almost good amount of information from those. So nowadays, in my practice, personally, I don't take any study model, neither scan nor the information. Alright. Then how do I do model analysis, Carey, Bolton, all these things? So we will teach you how to do it, train you how to do it. It is not possible for you as a clinician to go and sit and take model, then sit, take a ruler and start calculating all these things for every patient. And also it doesn't hold true. I mean, even if you do it, you will not be able to use it clinically. I will show you why. Okay? So these are all theoretical concepts, and they are being taught in courses at universities just to make themselves relevant, so that you feel that you have learned something and you are engaged and you waste your time and never apply it in your life. So you feel good here and feel stuck outside. Maybe you will feel miss out here, maybe you will feel, oh, other courses they teach model analysis, they teach bioprinting, but we are not taught. But later when you go out, you will be able to solve a case easily rather than getting stuck in choosing which one to use. Understood? So, after doing this model analysis, what is the information which you are requiring? There are so many. There is Harkavas, there is Carey, there is Bolton, there is Ashley House, there is so many analysis. But by doing so many analysis, what information do you need? You may have 100 information, but if you don't know what you need, you can't use it first thing. And if you have too much information, you don't know which information is relevant. So, to filter out all the noise, there is two important information you need to treat your case. First thing, is the space available in the arch enough for me to align my teeth or not? That means, is there tooth length, tooth material, arch length discrepancy or not? Space available is enough for me to align or not. This is the first information you need. If you have enough space, you align the arch without any problem. If you have excess space, you close the spaces. If you have less space, you create space by different methods like extraction, IPR or discolorization. So far clear? So this is the information you need. This is the information you derive from various analysis. The most important one is Carey's arch discrepancy analysis. Second information you need is whether the ratio of upper teeth material and the lower teeth material are in synchrony or not. Example for that, understand this clearly and you will solve 50% of your doubts regarding borders. This is the mouth of the upper body. This is the cap. So the cap fits in perfectly, isn't it? Everybody is following this? Is the cap exactly the same size of the mouth of the understand them, but you don't need to perform them. Once you have understanding, you as a clinician, you will be able to make these decisions without performing the model analysis actually. So far the concepts are clear. We need two information from all the model analysis, which is how much space do we need to align the teeth in that arch. That means difference between maxillary arch length available and difference between the maxillary tooth material. Because you want to align the maxillary tooth in the maxillary arch, not the maxillary tooth in the mandibular arch, isn't it? So same tooth is compared to the same arch. Whereas for upper and lower tooth to fit with each other, we require a ratio between upper and lower teeth, because upper teeth has to circumference the lower teeth. So there exists a ratio which is the Bolton's ratio. So far clear? So this is the relationship between upper tooth material with upper arch length and lower tooth material with lower arch length. This is for the alignment of arches. And for upper and lower tooth material to occlude with each other with a good ratio, we have another landmark which is a Bolton's discrepancy or Bolton's ratio. So far clear? So one is comparing the arch with the same tooth, whereas another is comparing upper tooth with lower tooth. So one of the records which we collected was pictures, another record we collected was models. In models we have to observe the study models and do some model analysis. The third record which we take is radiographs. What do we see in radiographs? OPG, cephalogram and IOPS. And what are we looking at in this X-rays? We have to look at the relationship between the upper jaw with the cranium, lower jaw with the cranium, upper jaw with lower jaw. Then we have to look at the relationship between the jaw and the teeth. Then we have to see whether all teeth are present, if there is any impacted tooth or not. If the teeth which we are going to treat, they have enough bone support or not. So these information will be available. Alright, now we have to filter out. So intraoral radiograph in orthodontics, when we take OPG, we will get almost 80% of the rough information, because OPG is a gross X-ray. It will not give you finer details. In most of the cases, OPG is enough. Ideally, because OPG, the center midline structure is overlapped by the vertebrae, it is not a good radiograph to evaluate the upper and lower anterior teeth. So ideally an orthodontic, ideally, not clinical. Ideally an orthodontic record should have a CEPH, an OPG, and IOPA for upper anteriors and lower anteriors. But in clinical practice, we can get a gross idea with OPG only. So we take OPG and CEPH in all ortho patient. If there is something which is important to us and we can't see it in a OPG, we aid it with a IOP. So far clear? Now again, if we have impacted teeth, you will have to take CBCT. So as the complexity increases, as you need more information, you can add up more X-rays to it, but the minimum is OPG and CEPH. You have to take this in all cases. Now other radiographs can be a PSF or a hand-raised X-ray. We have discussed this, it is not needed. So these are the two most important X-rays which we will use in our clinical practice, and we will discuss more about them. So first, what are we looking for? OPG. OPG, we are not doing any calculation, we are just looking for, as a dentist, what you will look for. You start from one side till the other side. So you look for the anatomy of the key and lip. Is there any discrepancy? You look at the two sides, if there is any discrepancy between the sizes of two contacts, if there is any resorption or not. So if nothing, this patient is healthy patient, then you come down, you look for any impacted tooth. We don't consider third molars in our treatment because either they will be extracted or they will be impacted, or even if they are present, we usually don't want them. Okay? So we will check whether third molar they need extraction because of some other reason, not for operation, because of some other reason. If it is needed, you can make that decision because you are general dentist, you are doing that dentistry. And for me, I look at it as an orthodontic perspective. So I usually don't comment for third molar for the patient. But you will see for any canine which is impacted or not impacted, any tooth which has any pathology. So these are general picture you will look for. Then you will look for root form, if there is any root resorption in any case or not. What happens if there is root resorption and all, we will discuss later. But for now, we are looking for pathology. So if everything clear? OPG work is done. OPG will be useful in later stages when we are bonding, we will discuss that. So OPG always should be there as a reference point. Coming on to SEP. Again, do you do cephalometric analysis always? Do you take cephalogram always? 100% yes. What is the information are we looking for? What is the skeletal problem? That is whether the patient is a skeletal class 1, class 2 or class 3. How do we look for? You do CNS analysis. Everybody have heard about CNS analysis. In BDS you were taught there is an exam where they ask you to check whether SNA, SNB, ANB, if ANB is more than 2, it is class 3. If it's more than 2, it's class 2. If it's less than 2, it is class 3. If it is 0 to 2, it is class 1. Isn't it? So you can get this information from cephalogram. Another information you want, whether the patient is a horizontal growth pattern or vertical growth pattern, you do 2-weeks triangle. And if your FMA is more than 25, it's vertical growth pattern. If it is less than 25, it's horizontal growth pattern. Then you want to check whether your incisors are proclined or retroclined. You can do upper incisor to NA, lower incisor to NB. This relationship is seen as analysis. Interincisor angle. These are the values which will tell you whether your incisors are proclined or not. Then you want to check whether your patient is growing or not. We discussed there are 3 methods. One is hand twist, which we don't use. Second is CBMI, we told you how to use it. And the third is physical features, which are not so accurate but a good guide. Then the third is we have to rule out any gross deformity. So, do you think you can get these information without doing the analysis? Could you get the information of skeletal problem in clinical examination? You could not? I told you we can get some information clinically. And we wrote down these values here. So could you get this information by looking at the patient, whether the patient has convex profile or a concave profile? I'm not asking you to quantify it. I'm not telling you it is increased by 1 millimeter, 2 millimeter, 3 millimeter. But can you get an idea whether maxilla is prognathic or mandible is retrognathic? Yes. Can you check clinically whether the patient's growth pattern is vertical, horizontal, or average? It may be, you may not be able to tell it is 28 degree or 32 degree or 23 degree, but at least you can tell whether it is horizontal or vertical. So you can get this information also clinically. Then can you see in the patient whether the teeth are proclined or not? So this information also you can get clinically. Nose skin lip relationship is a soft tissue landmark or hard tissue landmark. So definitely you can get it in the patient clinically as well. So do you really think is there anything which you cannot get from your clinical picture? CBMI you cannot get. So for that you don't have to do any analysis. So the point I'm trying to derive is the information you need, you can get a good idea without doing the analysis, but you still need the steps. So point is you need cephalogram, but you don't require cephalometric analysis in every case. In complex cases, you need it, you do it. Okay? So, cephalometric analysis, is it important for the diagnosis? Not really. In all the cases, no. Remember in your BDS when you studied essential diagnostic aid versus non-essential diagnostic aids or supplementary diagnostic aid, OPG was an essential diagnostic aid, whereas cephalogram was not essential diagnostic aid. That means for diagnosis, CEPH may not be absolutely necessary. I'm not talking about cephalogram, I'm talking about cephalometric analysis. In clinical practice, 80% of your cases, most of the decision you will be able to make out by looking at the CEPH without performing the cephalometric analysis. In remaining 20%, if are surgical cases, complex cases, or if there is a confusion, you can do cephalometric analysis. Do we do cephalometric analysis for all the patient? Will you do it? Yes, you will do it. Because nowadays there is new technology, you don't have to do anything, AI will perform for you. You will not sit with the X-ray and all, but we will teach you how to do it so that later on you are able to follow what is going on. Alright? So after this information, we know that cephalogram is important, but cephalometric analysis, it's your choice. And because we have now websites and applications which will do cephalometric analysis for you, we will make use of it. Previously, in first few batches, I was not teaching set tracing and all those, but there is a FOMO among students, right? That everybody is doing set tracing. Why am I not doing this? So that we incorporated it. It's okay. But anyways, you will see the usage as we progress in your. So this is not what I am telling. Again, anything which I tell you, it's not important. It's not my only experience. This is from Global Venezuela. It is equivalent to. It is better than Prophet. Actually, the orthodontic residents, they read this much, this more than Prophet. Prophet is basically an introduction to orthodontics. This is depth, and it says that cephalometric norms are a number racket. That means it confuses rather than helping. And you will see that. You will see in your patient looks class 2, but the cephalometric value is saying class 3, and you don't know what to do. So whenever you have this disjunction between clinical and number, you always follow clinical. Because remember, these numbers are for a different population. Your population is different. Secondly, they are based on averages. Your patient is not average. So you cannot directly use these numbers. Secondly, there are errors. What are those errors? Maybe you have not traced it nicely. Maybe you have traced a landmark wrongly. Maybe there is magnification of your machine is not correct. Also, there is superimposition of left and right, and you would have traced the wrong thing. So the idea is there's so many mistakes which can happen in cephalogram. Cephalogram is just another diagnostic aid which will help you concretize your clinical diagnosis. But if it is going against it, you will not base your treatment plan based on this, because you are not treating ceph, you are treating a patient. If a patient shows proclination, if the maxilla is forward and the ceph says it's not, and then you make the mandibular treatment plan, it is wrong, isn't it? You have to treat the patient, not the ceph. So there can be a time where you will find your clinical value not going hand in hand with cephalometric value, ignore the cephalometric value. PSF. We take PSF usually to detect facial asymmetries and planning orthodontic surgeries to correct those asymmetries. Because we don't do it, you don't need to know much about it. If you want to read about it, it's there in your notes. Again, CBCT, previously CBCTs were not available, or they were too expensive, or they were not available nearby in your clinical area, and you had to send the patient far off, they were not convenient. So they used to take different other x-rays like parietal x-ray, cone shift, tube shift technique, all those things. But nowadays we have CBCT, and it's easily available. Most of the clinics are around them, they have centers. So we take any impacted tool, we expect you to take CBCT to plan for it. Alright? At your level, I would say until you finish 5 to 10 cases, if you have impacted tool, don't take up. There are too many things to be considered in those. So when we take all these records, we have taken clinical pictures, we have examined the patient, we have taken X-ray, we have taken model. What are the questions which we need to answer after looking at this record? First question is, where would we want to position our teeth ideally? This is what we want to check, right? Whether the patient's teeth are in good position. If they are in good position, we will maintain. If they are not in good position, where do we want to position them? So where do we want to position them? With respect to the face, lips, we want to position them in a correct position anteroposteriorly and vertically. What is anteroposteriorly good position? Not too prominent with respect to nose, chin and lip relationship. What is vertical relationship? That at rest only 2 millimeters of inside the display is there, and when they smile, the entire teeth is visible. Yes? Then we want to know whether this patient is a good candidate for extraction or a good candidate for non-extraction. So you will analyze whether the amount of space, whether what is the profile, what is the nasolabial angle, what is spacing, amount of crowding, whether the teeth are procline or not. And based on all these things, you will decide you require extraction. So I spent the last 15-20 minutes to make you understand first, why are we taking this record? What information do you need to take from this record? Now we will see how to take this information with them. that we will have a separate session for model analysis, separate session for saprometric analysis, separate session for photographic analysis. So the basic concepts are clear, everyone? So once you have all these data, you will report diagnosis. How do you report? This is a dental diagnosis because it doesn't mention anything about skeleton. Then you have to make a case summary. So you have to report a 20-year-old, 21-year-old, 20, whether it's growing, non-growing, skeletal class 1, class 2, class 3, then angles class 1, class 2, class 3 with one or two of the most prominent features. Don't go on reading every single tooth. Don't go on reading tooth rotated, one or two most important feature, dental diagnosis and skeletal diagnosis. Growth pattern, growing or non-growing. Done? After you have all these things, you make a problem list. Problem list is something we jot down the most important problem in the sequence of their priority. I want to correct this first, this first, this first. Problem list doesn't mean the problem you can correct and you cannot correct. Problem list means you have identified 10 problems. Out of these 10 problems, 3 cannot be addressed because the patient doesn't want it or I cannot do it. Remaining thing, I will do it. Let's see. If the patient is a class 2 because of prognathing maxilla and retrognathing mandible. So this is the problem, right? Maxilla is prognathing, mandible is retrognathing. What is the solution to it? Do a surgery, cut the maxilla, put it back, cut the mandible, bring it forward. This is the solution. But are you going to do it? No. We are not addressing. We know this problem, we are not going to address it. Third problem is teeth are proclined. What is the solution? Retract it. Can we do it? No, we can do it. So the treatment plan would be to retract the teeth. So we make a problem list and then we make a potential solution. The problems we are not addressing, we are actually camouflaging them. Understood? But when you write an ideal treatment plan, the ideal treatment plan would be surgery. That's why I've omitted the problem list part from the list. Treatment planning. So if you plan to fail, then you don't plan for it. Alright? You got what I said? A fail to plan is plan to fail. So a treatment plan, see at your stage I will give you a very clear-cut answer. For me, when I take complex cases, I am standing here, I know the goal. Sometimes I do not know what are the steps I need to take that goal. But out of experience, I know this is achievable, this is achievable, this is achievable, and that is achievable. So if I can see that kind of goal I can achieve it, I will take up that case. Maybe I don't know the entire path from the beginning. I keep altering my plan according to the treatment response. But at your stage, what will happen is, if you take a case where you cannot see a potential solution to it, and you take up this case, then you will not know how to modulate because you don't have that experience. That experience will only come not by teaching, but treating more cases. Understood? So in your situation, when I will tell you that, okay, this is the case, this is how you will do it, but the steps are not clear as of now, and we have to see the treatment response, hence you refer this case, so refer that case, alright? Sometimes I will take complicated cases, even I will not know exactly how I will proceed step 1, step 2, step 3, step 4, step 5. But I know this is achievable and I know the first 3 steps. The remaining I will see, I will re-evaluate the case at a later stage. Similarly for you, it may be possible that you can imagine at this stage, you may not be able to imagine even step number 1. But I will do that job for you, I will guide you. This you can take, this is the first way you. And over a period of module 2 and module 3 and module 4, by that time you will be able to make a treatment plan by yourself. So first 2 modules, the idea is to start a case. I will guide you how to bond, which route to bond, whether to bond the incisor or not. You will not be able to make that decision in first 2 modules. It is okay. So don't feel overwhelmed, but you can still start the case. I will be guiding you. Slowly you will develop this ability. So while planning, we have to consider growth. We have to consider etiology, we have to consider whether we require space. If we require space, what are the methods of requiring space we can get? We can extract, we can IPR. Whether to extract, whether to IPR, whether to do both, all these are decisions to be made when we are planning for a case. Understood? In current scenario, previously there was a time where every patient, every case they were extracting tooth. They were following like a cult. Then before that there was all a group who were not extracting in any case. That is another cult. But yes, we have that cult still existing. A lot of not well-versed Damon practitioners, I'm not talking about people who are using Damon, I'm telling the people who got sold by the representative and using Damon, they think that Damon means non-extraction. You have heard Damon, that is the Damon basis type. The marketing, the medical representative who is selling you this, they will misinform you that this is a non-extraction orthodontic material, but not an orthodontist. An orthodontist or a Damon person who invented Damon or who come up with the Damon system, he also extract teeth with Damon basis. So this is what we are sold by this. So if you are not well educated about your specialty or the treatment which you are planning, you may get missold. So the idea is nowadays we have this newer materials. If it is a borderline case, remember borderline case? If it's a borderline case where you can make an extraction decision or you can make a non-extraction decision, and for some reason you want to do non-extraction, some of the treatment modalities can help you achieve that easily. But if it's an extraction case, whether you use Damon or you use Invisalign or you punch the patient in the mouth, you will need extraction for that. Understood? So the treatment plan is to be decided irrespective of the appliance, but in some cases where an appliance has an added benefit, you can choose that to execute your plan. So far clear? So we do extract nowadays, still we will extract in most of the cases if it is needed, but not only for the space. If only for the space, if the crowding is too severe, 13-14 millimeter, you do for extraction for space. If the profile has to be changed, you do extraction for the profile. If it's a borderline case with crowding and profile change, you do extract. But if its space is good, it's a borderline case, mild to moderate crowding, you can do away without extraction with certain modalities, and we will discuss them over a period of time. So far clear? So don't think that extraction is going to reduce your airway and you'll have airway problem and this and that. Nothing, no TMJ problem, no airway problem has been concretely established by any research or literature so far. So whenever a sleep medicine people is presenting the paper, they are cherry picking the data. There is no concrete RCT establishing this fact. When TMJ people are there selling their splints and everything, they are saying orthodontic patients have TMJ problems and they're cherry picking the data. But the RCT studies, the meta-analysis, nothing has been established. Okay? Otherwise, orthodontic specialty would have shut down for a very long time. So don't get sold for this. We discussed treatment modalities. Remember, sometimes you are not clear whether to extract or not. We showed you a case, isn't it? There you can test your response. That means it is called therapeutic diagnosis if the case permits. Now which cases you can permit, which cases you cannot permit, we will discuss that later, don't worry. But the idea is there is an option of delaying your extraction decision if you are not so confident or if you are not so sure. We will discuss everything in detail. This is just an outline. So let's see this case. The profile here, by now you should be able to judge profile, crowding, non-crowding, class 1, class 2, class 3. You should be able to do it. So let us answer a few questions here. Frontal rest. Lips competent or non-competent? What you see, you answer that. Competent. Smile. Inside the display, normal, increased or reduced? Normal. What about the profile? Convex, concave or straight? Convex. The patient looks class 2, class 3 or class 1? Class 2. Upper arch crowded or spacing? Lower arch crowding or spacing? Upper arch crowding mild, moderate, severe? Mild. Mild to moderate or mild? Lower arch crowding mild to moderate or severe? That means we have two objectives. Upper teeth proclined or normally inclined? Proclined. Lower teeth normally inclined or proclined? Mild proclined. If you are confused, you can go on to the bottom. So we have now two objective, one dental objective, one facial objective. Facial objective is to reduce the convexity of the face. Dental objective is to correct the inclination of the upper teeth, maybe potentially improve the inclination of the lower teeth. Also to improve the canine and molar relationship and align the tooth. Yes? Now looking at this case, first thing, the nasolabial angle is near normal. Near normal. That means if I retract, I should retract enough but not too much also. Secondly, I want to improve the inclination of the incisors. Alright? And there is overjet which is not so severe, because if you see only the lateral incisor is blocked out, once you align them, the overjet will change, isn't it? The teeth are going to procline slightly. So I'm not clear about my overjet as of now. Remember, overjet keeps changing throughout your treatment, because when you have crowded tooth, your teeth is like this. When you align them, they will become like this. This will later reveal you the real overjet what it is. Understood? So sometimes you cannot make this decision whether I should extract. Should I extract here all 4 premolars? Should I extract here upper 4 and lower 5 premolars? Or should I extract here only upper premolars? So what do? Go with the option which I am very sure of. What were the 3 options? Upper 4 extraction, upper 4 lower 5 extraction, or all 4 extraction. So what is I am sure of? Upper 4. So start with upper 4 extraction first. So first we will do upper 4 extraction, align the tooth. Later on we will see. Now there is remaining space in the upper arch. Less space here, more space this side. That means we want to retract further to close the space, isn't it? Also we need to correct the canine relation this side. Now because we have retracted the upper, aligned the upper, but lower we did not extract. We will discuss this case in detail stepwise. For now, this is the step where we want to make the decision. There is no overjet. So without overjet, I cannot retract further, right? To create this overjet, what I have to do? First I have to take the lower back, and then I can take the upper back more. Now I need to create this space. How can I create this space? By lower extraction. But if I extract 2 premolars, it will be too much space for me. So sometimes we have to set a compromise. And in this particular case, I have extracted a single lower incisor extraction. Now this is very, very rare. You will never plan for it. I showed you one of the toughest decision cases in the beginning to let you know that sometimes you may end up in this situation. So it's not usual to extract the lower single incisor. But sometimes we have to make this decision because it's not an easy decision to make which tooth to extract. So in such cases, it is okay to delay the extraction in the arch which is confusing, proceed with one step, then slowly determine further. Understood? Now, please, I have shown you this case, I am telling you, don't plan for this. Alright? In your practice, if you are thinking, shall I extract lower incisor, think you are thinking wrong, plan again. Plan again. If 5 times you plan and still cannot come up with any other plan, probably then there is a possibility that this may be a treatment plan. Should not be a first treatment. Okay? So if you see here now, I was able to finish the case nicely. Now let us evaluate this case. Profile improved or worsened? Improved. Overjet improved or worsened? We have a functional class 2 molar relationship with good interdecitation posteriorly. Class 1 canine, good overjet and good overbite. So our Andrews first key is balanced by all the other things, isn't it? There is good inclination of upper and lower teeth, mesiodistally and labiolingually. So second and third keys are balanced. Then we go ahead and check whether there is any crowding or spacing. No crowding, no spacing. So fourth and fifth key is established. And the lastly, curve of speed. There is no deep curve of speed. You have normal overjet and normal overbite. So fourth, sixth key is established. That means we have achieved all the goals which we wanted to achieve. Plus, you may say that the lower midline is off. When the patient smiles, can you see the lower teeth very clearly? You cannot see it. It is a aesthetic problem. Functional, there is no functional problem. Class 1 canine is achieved. Incisor, overjet, overbite is achieved. That means it is not a problem. So, if your lower midline will never match when you extract these kind of asymmetric extraction pattern, and it is accepted. Is it clear? So now this is again an excerpt from the Weber-Bernstein textbook, and it says that most of the time, if we just keep taking records, we cannot use them appropriately or judiciously. 80% of your orthodontic cases, we can answer these questions that whether my patient will benefit with orthodontic treatment or not, if he will benefit, whether they will require what sort of appliance, functional appliance, fixed appliance, bone or orthodontic surgery, and if we are doing any treatment, whether they will require extraction, non-extraction or surgical procedure, and how much time and how much cost will take. These all questions will be answered without taking too many records. You will require self, clinical examination and OPT to make this decision. Understood? Any further records which are taken has to be justified whether you require more information or not. Is this point clear? So this was the end of your diagnosis and treatment planning. This is the consent. Before we go to the next part, which is symmetric tracing, it is your turn to answer to the question. What do you think? Extraction or non-extraction? Now we discussed so much, right? Look at those features there and try and answer. How many things extraction or non-extraction? Extraction? Anyone? Non-extraction? How many? What about the remaining? Confused? Why confused? Yeah, go ahead. What do you need? Intraoral. Very good. Anybody who made decision did not learn the lesson from the previous picture. So you require more records, right? Let us give you more records. This is another patient and that is another patient. Sisters. Now, can you decide? No? You need more? Now can you decide? For patient on your left, is it extraction or non-extraction? What do you think? Patient on your right? That means with same facial features, you can have different extraction pattern. You can have extraction or non-extraction. So you have to look the patient as a whole. You cannot base only on deciding on the facial features or only on the intraoral features. The reason for extraction, so you have to see soft tissue, you have to see amount of crowding, you have to see profile, and you have to see everything else. Alright, you cannot decide only on one feature. So if you see the final result appears to be similar for both, this is the final result. Pre-treatment and post-treatment profile, pre-treatment and post-treatment profile for both the patient are unchanged. But in one we did extraction, another one we did non-extraction. The idea I want to tell you is, extraction or non-extraction doesn't change your profile if you don't want to do it. How you use that space depends on your management. In this case, we decided to extract because this patient had very tight soft tissue. Remember we discussed, so we cannot afford expansion and non-extraction treatment. Whereas this patient, her sister, she has very lax soft tissue. Even the amount of crowding was not too much. Her gingival strength or gingival structure was very good compared to the sister. So we tried non-extraction for her and we could achieve the plan without any problem. So what do we learn from that? That different treatment plan can lead to same result. It is how you manage the spaces will help you achieve the goal. We will discuss this. Anchorage will come in module 3. Anchorage is the one which will make or break your cases, how you use the spaces. We will learn in module 3. But for now, we have to just understand whether these things, how is it relevant or not. Clear? Take a small break, 5 or 10 minutes.